Hi, everyone. It's Dr. Watkins here. Happy Friday. I'm really excited for today's webinar. We are going to be talking about cervical dysplasia, HPV, or the human papillomavirus, and then some naturopathic approaches to how we treat those conditions. So let's jump right in. So, naturopathic approaches to cervical dysplasia. So before we get into today's topic, I think it is always appropriate for me to just discuss our naturopathic principles. So these are some pillars that, as a naturopathic doctor, I really lean on these whenever I'm assessing a case, or I'm trying to come up with ways to address my patient's concerns. This is like my North Star. These are my founding and guiding principles. The first one is first, do no harm. Second, identify and treat the cause. Third, treat the whole person. Fourth, the healing power of nature. Fifth, the physician as teacher. And sixth, prevention. So you'll hear me mention some of these principles as we go throughout the talk, and just talk about how we can make addressing cervical dysplasia a really individualized condition and approach. Objective. So, what exactly are we going to be talking about today? We are going to be reviewing the risk factors for cervical dysplasia and HPV, the screening guidelines and what that looks like depending on your age, prevention, what we can do to prevent HPV and cervical dysplasia, and then different treatment options in the conventional world and in the naturopathic world. So, some anatomy. Let's get acquainted with our reproductive organs here. So, we are primarily going to be talking about the cervix today. As you can see at the very bottom of this pictograph, we see the vagina and the vaginal canal. Right beyond that is the cervix. The cervix is the entryway into the uterus, into our womb. Today, we're going to be talking about the endocervix, which is the inside of the cervix, and then the ectocervix, which is the superficial layer, that surface layer of the cervix. As we move up into from the cervix into the uterus, we see the two fallopian tubes on the side, and then we see the ovaries there. What exactly is dysplasia? So, whenever you hear this word dysplasia, that is a medical term that means that there are abnormal cells, so changes in the ways that the cells look in a particular part of the body, and they're typically precancerous. Now, just because you have cervical dysplasia, it doesn't mean that you have cancer. Dysplasia is just a term for us to quantify that there has been a change in the cell and they are no longer normal. Today, again, we're going to be talking about the difference between endocervical cells, so cells that are inside the cervix. These abnormal cells are usually more concerning for your practitioner because that means that there's more of a risk for those cells to have change going towards the uterus, which we don't want to happen. Ectocervix is the most common thing that we'll usually see in pap smears and HPV. This is what we typically see first whenever we're doing pap smears and we're assessing that area. That is the superficial layer of the surface of the cervix. So whenever you look at the cervix, what we're actually seeing is that ecto part. And then when we're talking about dysplasia, we have to really talk about the different range and scale of changes that we can see. We're going to be talking about three particular types of cellular changes today because those are the most common that we see in practice. But know that there are many different ways that we classify how far the cells have changed. And this picture here is just a really cool example to just give us a simplified version of those big categories. So in this top left corner, we see a normal cell. So we see how the cervix looks nice and smooth. It's pink. We don't have any eruptions or lesions there. On the bottom left corner, we see a low grade change or a low grade of dysplasia. This means that the cells have started to change, but they haven't progressed in their severity quite yet. They're still on a very low level of change. And then we have a high grade. So this is the bottom right corner. As you can see, the lesions are more noticeable. We are definitely seeing inflammation on that surface level of the cervix. We're even seeing some erythema, so some redness, and it looks like some erosions that are starting to happen. And then at the very top right, we see cancer. So cancer, the main thing about cancer is that it is proliferative. The cells are proliferating, they are multiplying very quickly. And when that happens, this puts us at risk because those cells grow, they spread, and then they spread to other areas. Not only do they spread in the tissue, but they go deeper in the tissue. So it's almost like a seeding. It's like the cells create this seed, and from there, they just continue to grow, and then eventually they take over that whole area. So you can really see here how different a normal tissue looks in comparison to cancerous cells. All right, so how do we get cervical dysplasia? How does that happen? The most common reason that we see cellular cervical dysplasia is HPV. HPV stands for the human papilloma virus. Now, this is the number one sexually transmitted virus in the United States. It is extremely common. Over the last 2 years, we all have been surviving this pandemic. Um, COVID is what we are hearing for the last 2 years. But I always like to educate my patients that the silent pandemic is HPV because so many Americans, particularly our younger women, experience HPV. I see it all the time, and it is concerning at the numbers that we're starting to see. There are some here, there's something like 42 million Americans have HPV. They've tested positive for this virus. Over 13 million Americans contract the virus each year. This is particularly in our younger age group, so teens, late teens, early 20s. We see this in this age group because they are usually exploring sexual activity for the first time. They're going off to college, hormones are changing. It is not uncommon for our young adults to be having sexual intercourse without protection and really knowing how to protect themselves. So we see it a lot in that age group, and the numbers are staggering. It can affect women and men. Today, we're going to be focusing on women primarily, but men also contract the virus. We can see HPV in the vaginal tissue, in the cervical tissue, in the anal tissue, and the throat tissue. We contract it through sexual intercourse, whether that's vaginal intercourse, anal, oral sex, or just intimate skin to skin connection. It is typically asymptomatic. So this is what makes HPV that silent pandemic that I like to refer to it as, because most people don't have symptoms. We really don't pick up on HPV until we start to do those screening paps, or unless HPV has progressed for years, or we have a really aggressive strain, and all of a sudden the patient is starting to have symptoms, which usually is very severe because it's asymptomatic. This is why screening and prevention is so important, because we don't really have any other ways to find this virus in the body. We have over 100 types of HPV. We're going to be talking about the most common types today in this presentation and what I see in clinical practice. Um, it is self-resolved in most cases. So this is an important point. In my younger patients, meaning less than 30 or so, we don't typically worry as much about that person being able to fight the virus. There's tons of research that shows us that women less than the age of 30 usually resolve HPV on their own. It can be a self-limited virus. However, it really depends on the person. It is very individualized. It depends on their health status. It depends on the type of strain of HPV they have. Do they have a high risk strain? Do they have a low risk strain? Um, what is their nutritional value? Are they a smoker? Do they have any autoimmune conditions in the background? Any chronic inflammation in the background? All of those factors will decipher if that person is able to beat it on their own or not. Yes, we look for women under the age of 30 to fight it on their own. It doesn't mean that if you're over 30 that that still can't happen for you. I've seen patients in clinical practice where once we have some support and we're being aggressive about addressing HPV, these are women in their mid 30s, early 40s, late 40s. We do see improvement in their cases. So age isn't everything, but it is an important factor when we're talking about HPV and self-resolvement. Elimination versus suppression. So this is a really hot topic in the medical community about HPV. The question is, can we ever really get rid of HPV? Or do we just suppress it to where it doesn't show up on our screening labs anymore? And that's a really valid question and a lot of concern that I see in clinical practice. I've had patients where they've had a history of abnormal PAPs. We treat them, and then for a year or 2 years, everything is completely normal. It seems as if we have eradicated the virus and there are no cellular changes on the cervix. I also have patients where maybe for 1 or 2 years they're clean, and then all of a sudden something happens, whether it was a stressful environment or diet change, or there was a new sexual partner, whatever, and the virus then presented itself again, which makes you question, did we ever really get rid of it, or did we just suppress it enough to where our sensitive screenings weren't able to give us that positive pap anymore? So there's a lot of back and forth on this. I like to think about it being suppressed versus eliminated. If you know anything about viruses, you know that they make a home in our bodies. They make a home in the host. It's a little bit different than bacteria. um, with antibiotics and science, we have a little more reign over bacteria. We can eradicate bacteria much more easily than we do with viruses. Chickenpox is a really good example. If you're exposed to chickenpox in your younger years, there may be some risk that you have an outbreak of shingles in your later years in life once you're an elder. And this can happen with stress. This can happen with other viral infections, other autoimmune conditions, chronic conditions. Whenever the body's under stress, we start to see that there's a reactivation of that virus. And we call that shingles in a later adult onset. It's the same virus as chickenpox, right? So that shows us again that viruses live inside of the body, which is why I like to think that we suppress them. I don't think we ever really eliminate them. However, that is still up to be determined. We need more research to determine that at this time. Risk factors. So let's dive in a little bit deeper to some of the risk factors that may predispose a woman to contracting HPV and having or showing signs of cervical dysplasia. So, age, that piece is really important. Less than the age of 30, patients usually have an easier time of kicking it on their own without any intervention. Once we get older, it's harder for the body to fight it without us doing anything there. So, that's important. If we have a history of smoking or if we do smoke, this really, really decreases our ability to fight things. It suppresses the immune system. It creates massive inflammation and cellular changes as is just from the oxidative damage we get from inhaling those substances. So that's a major risk factor. Autoimmunity is another one. This makes a lot of sense to me. If the body is fighting something continuously, with autoimmunity, our body is mounting an immune response that is attacking itself. If that is happening in the background, it distracts the immune system from focusing on the HPV and being aggressive at treating that. It already has a boiling pot on the stove. So it's a little bit harder for the body to modulate the immune system when there's already an autoimmune process. So if that's on board, we know that the patient may have a harder time fighting it, or they may be predisposed to it if they haven't been exposed already. Chronic conditions and inflammation. So, for my patients with diabetes or obesity, hypertension, um, hypothyroidism, rheumatoid arthritis, what else? Hashimoto's, um, metabolic syndrome, those chronic conditions that we see, um, chronic UTI infections, sinus infections, weakened immunity. We know that those patients are at a higher risk factor because, again, the body is in the background trying to fight these conditions that have this chronic piece. It makes it harder for the body to really hone in and fight the virus. Hormonal imbalances is really important. So for my women who notice irregularities in their cycles, whether this is PCOS, polymenorrhea, so cycles are happening every 2 weeks, amenorrhea, there's no cycle, oligoamenorrhea, so just a super irregular cycle. One cycle is 60 days, one cycle is 26 days. Any of those hormonal irregularities, that puts us at a higher risk for HPV and cervical dysplasia because this tissue is very responsive to our hormones. I like to think of estrogen as our fertilizer, and I like to think of progesterone as her sister that tells her to calm down. So, in our hormonal organs, we have certain receptors and we have tissues that are responsive to those hormones. The most noted one is our uterine lining. So, in our uterus, in the first part of our cycle, we are stimulated by estrogen. Estrogen tells our uterine lining to grow tissue, to get that grass nice and plumpy, with a lot of vascularity, so that we can then wait for the egg to be ovulated, released in the second half of the cycle, and wait for the sperm to make its way up. And then we have implantation and so on and so forth. That is important because we need that cyclic hormonal intervention for that process to happen, for pregnancy to happen. If pregnancy isn't happening, if that egg is not fertilized, our body gets that signal. Both of those hormones, estrogen and progesterone, drop. And that's when we have our periods. So that's just the clearest way to articulate how our tissues are responsive to estrogen and progesterone. If that is not happening on a regular basis, we run the risk of having other issues that pop up because we're not in sync there. And that's where that hormonal imbalance piece can come from. If we're having a lot of estrogen grow tissue, but we're not having enough progesterone to oppose that, that puts us at a higher risk of that tissue being really responsive to a virus. Poor nutritional status. So these are for our individuals who may be eating a standard American diet. So in a standard American diet, we are typically heavier in our simple carbohydrates, in our fatty foods, our fried foods, our processed food. Is it a very low nutrient diet? We're not really getting vitamins and minerals and the nutrition that we need to maintain health. When that happens, our body doesn't have the tools it needs to fight a virus such as HPV. Immunosuppressant medications. So when we have those autoimmune drugs on board, we typically have immunosuppressant medications to keep that disease process from progressing. It decreases your immune system. It's just as simple as that. With autoimmunity, we want to calm down that hyperreactivity, and we do that through medications. Not only do we calm down the autoimmune condition, but we're also calming down just our regular immune system, which then makes it harder for us to fight the virus. Contraceptives, so birth control, mostly oral contraceptives. This ties into that hormonal imbalance. When we're on oral contraceptives, we are getting exogenous hormones. We're getting hormones from the outside that influences the way that our brain then communicates to our reproductive organs. And then that decides if we have a period or not, if we ovulate or not. So, again, those changes make that tissue more susceptible to the virus. Genetic mutations and family history. So we definitely see a connection between family history. So the women in the family, they have a history of HPV, cervical dysplasia, cervical cancer. There's usually a connection there. Genetic mutations such as the MTHFR gene is very popular. Unprotected sex is the number one risk factor. We know that we get HPV through sexual intercourse. So if we don't have that protection there, we are definitely at risk. Sexually transmitted infections are another risk factor. Again, the immune system, if there is another infection in the mix, the body has a harder time fighting the HPV and then the gonorrhea or the chlamydia or the HIV or bacterial vaginosis or chronic candida or fungal infections. There's already a process going on there. So when we compound it with HPV, it's a little bit harder for us to kick both. Sex before the age of 18, and this because is those cellular changes. So hormones are still changing there. The tissue is still changing. We're going from an adolescence into adulthood. So as a woman starts to mature sexually, there are different changes that are happening to her reproductive organs. And then the number of sexual partners that you have. So the more sexual partners that you have, especially if you're having unprotected sex, the more at risk you are to contracting that HPV, the human papillomavirus. Screening. So this is arguably the most important part of the whole talk, because this is how we get a read on what is going on in the body, and is if HPV is there, and if it's there, how severe is it, what do we need to do about it? So when we talk about screening, we're really talking about the pap smear. That's our first test, our first screening in terms of HPV. So this is usually every year. You do this when you see your doctor. We call this your well woman's exam. And we're looking for a few things here. So we're looking at the cytology, which is the actual cells of the pap. We're looking for HPV. So if cells are abnormal, is the virus there? And then I'm looking for the type of strain, right? So if HPV is there, I want to know what type of strain they have, because we have low risk strains and then we have high risk strains. And that's really important to me as a clinician to know if I'm treating a really aggressive type of HPV or if it's a less aggressive type. And then a colposcopy, which is what we do if the pap comes back abnormal, if there is a positive HPV and we need to get a more definitive diagnosis. So that's what we do in the pap. During your PAP, if you've never had one before, you go to the doctor. She or he will typically observe the external genitalia, so to make sure that there's no lesions, no inflammation, no abnormal discharge that we can see with the naked eye. And then we have the speculum exam. So we actually go inside the vaginal canal so that we can visualize the cervix and take a look at the cervix and see if there's anything that we can see there right on the surface of the cervix. If we have a woman and she has no prior history of HPV or abnormal PAPs, these are the guidelines that we typically follow. Now, if there is an abnormal history, these guidelines do not apply. Okay, so I just want to make that really clear that what I'm about to discuss is for patients who don't have a prior history. They may not even be sexually active yet. This is usually where we start. So if they're less than 21 years old and they have not had sex, it's not important for us to start screening. Once they start having sex, most guidelines recommend at least within the first 3 years after that first sexual encounter, regardless of their age, we want to start getting the guidelines and the screening there, because we know that that exposure is there or could potentially be there if safe sex is not being practiced. Once we get into 21 to 29 years old, we start looking at the cytology only. So most doctors are not testing for HPV here. We're just looking to see how the cells look. Are the cells normal? Are they abnormal? And if they are abnormal, how abnormal are they? Now, again, this is this age piece, 21 to 29. These women are most likely going to kick the virus on their own. So most conventional docs are not worried about looking for HPV. They just want to see if there's cellular changes. Once we get to 30 and 30 all the way up to 65, most guidelines are recommending that we start testing for HPV and that we are at least doing PAPs every 3 to 5 years. For a woman that's over the age of 65, if she does not have a history of any moderate to severe dysplasia, we usually stop PAPing there. Now, these are conventional guidelines. As a naturopathic doctor, my guidelines are a little bit different. If I have a patient who has a prior history of abnormal PAPs, I'm not going to wait 3 to 5 years to repap her again. I want to repap her every single year. And the main reason that we have that difference there is in naturopathic medicine, there are so many things that we can do to address HPV and to address cervical dysplasia. It's worth our time to check every year because we can see a lot of changes even within 3 to 6 months, depending on how aggressive the treatment is. So for me personally in practice, if I have a patient that is sexually active, and certainly if she has a prior history of abnormal pap smears, I want to see what's going on every single year. Depending on how severe, if this patient has a high risk strain, and if her cellular changes are more moderate to severe, I may even check every 6 months or every 3 to 6 months, depending on what we're working on. Once you have a hysterectomy and we have removed the cervix, Most guidelines don't recommend continuing with screening as long as there was no history of severe dysplasia in that vaginal canal because the cervix is no longer there. It has been surgically removed. I always like to encourage my patients to continue their screening despite their sexual activity. So even though they may not be sexually active anymore, or it may be years since their last sexual encounter, cervical cancer can take years to grow. So just because sex isn't happening in real time right now doesn't mean that we want to turn a naked eye to what could be happening to the cervix. If there's been any sexual exposure, especially unprotected sex, you still want to have some type of routine screening because those cervical cells can change over time. Maybe in your 20s you were exposed, but you were so healthy it didn't show up on the pap. Now that we're in our 30s and our 40s, it is not uncommon to see patients have irregular paps later in years, right? And that goes to that eradication versus suppression piece. Did we really ever get rid of it, or was the virus just dormant and then it showed up later in the years? So that's why I like to encourage patients to continue with their well woman exam every year to make sure they're getting that regular screening. Screening guidelines, it really is up to the physician's discretion. Like, again, every person is different, every history is different. Sometimes there are children in the mix, there are different partners in the mix. If there's a history of bacterial vaginosis or chronic yeast or other pelvic inflammatory conditions, other sexually transmitted infections, you may be getting screened more often because of that history. If none of that stuff is going on, and you're in a monogamous relationship or you're celibate, the situation is just different. You may be able to get away with doing less exams. I want to talk a little bit more about the low risk and the high risk and just give you some numbers to put in your head. So, when we think about high risk strains, the two types that are the most concerning is type 16 and type 18. So, whenever you get your PAP and if it comes back abnormal, so the cells look a little bit different, we then check to see if HPV is there and then we type that HPV. If 16 and 18 comes back positive, then we know that we have a more aggressive type on our hands, and your doctor will most likely want to see you a little bit more often because of that risk. Low grade types, type 6, type 11, those are the ones that we typically see with genital warts or benign lesions. They're not really associated with cervical cancer, so they can be there, but we don't typically worry about them. So this is just giving us a pictograph on the severity of dysplasia that we're looking for on the PAP. So right here on the left, we have a normal cervix, right? So this is someone who doesn't have any abnormal cellular changes on their cervix. The first step outside of that, and I see this one a lot, is called ASCUS. ASCUS stands for atypical squamous cells of undetermined significance, which basically means there has been a change in the cells, but we're not quite able to classify it yet. We can't really tell how low it is or how high it is. We just know that it's abnormal. The next state from that is LCL, which is low grade, so a little bit more progressed than ASCUS. And then we have CIN1 and CIN2, which are the next two phases, and that is considered HCL, which is high grade squamous intraepithelial lesion, right? So that's how we scale with the PAP. When we get that sample and we get that report back, we're looking to see are cells normal? Are they low grade abnormal? Are they low normal? Are they moderate? Are they severe? And then from there, it'll help us to decipher what our next steps are. If the PAP comes back abnormal, and let's say the patient has ASCUS, so there's a very low grade change, but her HPV is positive and it's a type 16, which is one of our higher risk types. If that is happening, then we are going to refer that patient to get a colposcopy, which we'll talk about now. So a colposcopy is another diagnostic test that gives us a definitive diagnosis on how much those cells have changed. Remember, The PAP is just a screening test. That's our first pass. If anything comes back funky there, we want to go back in there and get a small biopsy so that we can look at the cells a little bit more closely and really decipher and grade our patient. Where are they? Is this truly a low grade cellular change, or is it a little bit more progressed than we thought on the PAP? And this is why the colposcopy is very, very important. I do have some patients that express a lot of anxiety over this procedure. Getting a well woman's exam, doing a speculum exam, it is invasive, it is uncomfortable. No one likes to do this. And the colposcopy is just as invasive. The difference between this procedure and the screening PAP is that we do take a small biopsy. It is small. It's about the size of a sesame seed. But I do have patients that experience some light cramping after. Sometimes they feel the cramping actually during the procedure. I usually recommend that they take ibuprofen before they go, just so that they have that inflammation response is a little bit less. There's a little bit less pain after that. But you go in, your cervix is cleaned. We take a look. We get a small sample, a small biopsy, and then we look at those cells a little bit more closely so that we can really grade the level of inflammation and cell changes there so that we have a diagnosis. Prevention. So now we're going to switch gears here. So, how can we protect ourselves from HPV if we already have it, if we don't have it? What are some things that we can do to decrease our risk? So, the number one thing is limiting our sexual partners, or at least practicing safe sexual practices with those sexual partners. HPV is a sexually transmitted virus, it happens during sex. So, if we're going to be having sex, penetrative sex, we want to make sure that we're protecting ourselves, especially if we have multiple partners. The really sad thing about HPV in um, hetero couples is that it is always asymptomatic for men. So men almost never know that they have it. Women don't know that they have it until they get screened. So it is very easy to pass it along through sexual encounters, especially in those younger years where we know that there's typically more sexual activity. Younger individuals, um, I don't want to assume, but research has shown us that they're less likely to be practicing safe sex with every encounter that they have. Because of that, that's why we see such high cases. And that, again, that's why we call it the silent pandemic, is because you just don't know you have it until you start getting your PAPs. So, this consistent use of condoms is very, very important. Avoiding smoking is another huge risk factor, another way that you can protect yourself. Regular screenings. Again, this is why it's so important. If you have a new sexual partner, you should be screened after that if you're not practicing safe sex. Because if there has been multiple partners and there was no screening, it's very hard to pinpoint where you could have contracted it from. And then lastly is the vaccine. So we have three types of vaccines against the human papilloma virus. I'm not going to go into this too much because there's a lot of research and debate on the efficacy of the vaccine, the side effect profile. This vaccine is still fairly new to us in the grand scheme of the world. Of science world, we're starting to get some data from when it was first introduced about 15 years ago or so, but we're still studying it. So I always recommend patients that definitely look at all of your options. I am not against vaccination, but I am pro individualization. So looking at the risk factors, seeing what your risks are, and then really talking it through with your provider to see if that vaccine is something that you should consider or not. All right, so what are some treatments for cervical dysplasia or some abnormal cells on the cervix? What do we usually see in conventional treatment? So, with conventional treatment, we are either doing mechanical intervention, which is the LEAP or the cone biopsy, or we're waiting and we're watching. So, when I say mechanical removal, I mean that we're actually removing the cells from the cervix. The most popular type of procedure is the leap. And with the leap, that's the one that we see here on the left side. That's when we they have an instrument and they literally shave off that top layer of cells. The pros to doing some of these more conventional therapies is that if you have a skilled practitioner, they usually get all of the dysplasia in one round, right? And we can make sure that we get it because we're mechanically removing it. On the flip side, there are risks and room for complications after that because the cells are more vulnerable. And depending on the practitioner, humans make mistakes. We have some surgical error there. If the leap extends too deep into that cervical tissue, then we can start to see some issues with fertility because we don't have that surface area anymore. And the cervix is really important for maintaining pregnancy. Remember, this is the doorway to the wound, right? It's also the exit way from the womb for the baby. We want cervix to be nice and tight when we're pregnant. And if that tissue has been removed, we have less of that tightness there. We can have more complications with pregnancy and fertility. With the cone biopsy, instead of shaving, we're actually going a little bit deeper into the tissue so that we get more of those cells out. And this is typically for cervical dysplasia that has extended into the more deeper levels of the cervix. The leap is for more superficial, cone goes a little bit deeper. Waiting and watching. So this is also really common in the conventional world. It's not uncommon for your gynecologist to tell a woman with an abnormal pap, let's just wait and see what happens. We'll retest in 6 months. We'll retest in a year, 3 years. There really isn't a lot of training for conventional docs in other modalities and therapies to treat HPV. So I see that a lot. I have patients that come in and they just want more answers. They want to know what are their other options other than just waiting for another 6 months in a year. And I'm always really happy to educate them on what that looks like. So this is a good segue into going into the naturopathic treatment, just to create a contrast of how I approach HPV and what I'm looking for when I'm coming up with a treatment plan. So the number one thing is treating the whole person and treating the root cause. I am not just treating HPV. I am not just treating your cervix. I am treating you, right? Your cervix is a part of you, which means that this body, this host, everybody is working together. Everyone is influencing everyone else. We all of our parts and systems and hormones and cellular messaging, they are all communicating with each other, which is why we need to treat the whole person. And we also need to treat the root cause, right? So I don't want to just make sure that the cellular changes are different. I want to treat the actual virus as much as I can, right? Us just having a regular PAP, that's awesome. But if we have a regular PAP and that high risk strain of HPV is persistent, to me, that necessitates me to want to continue with treatment. Underlying conditions and inflammation. So we want to make sure that we are addressing these things. And this is that treat the whole person, treat the root cause. If I have a person that has chronic inflammation for whatever reason, to me, that is the root, right? We know inflammation is the start of all disease. So in my mind, it makes more sense to just treat the host for inflammation. So then we can create more space for that adaptive immunity. That's our specialized immunity to really hone in on that HPV and to address that specifically. Nutritional deficiencies. So we want to make sure that we're addressing that. Is this patient getting what she needs in her diet? Is she getting the nutrients and the vitamins and the minerals so that her immune system can be healthy, so that her cells can regenerate in a healthy way? Is that happening or is it not? Stimulating the immune system. So if this person has a weakened immune system, we want to support it. Even if their immune system isn't weak, we still want to support it. And there's a lot of ways that we can do that with botanical medicine. So educating the patient on safe sex is also really important. Physician as teacher is one of our naturopathic principles. So I'm doing a lot of educating and advocating for my patient to help them with that health literacy piece so that they know how they can protect themselves. The MTHFR is that genetic mutation. Dr. Kalsa, one of the doctors at Living Wellness Medical Center, did an amazing presentation on this genetic mutation last year in 2021, I believe, around fall or so. You can find our webinars on our website. I absolutely recommend you go look into that. There's a lot of amazing research on that genetic mutation and how it can affect us. And then lifestyle modification. So this is exercise, this is stress management, this is diet, this is self-worth, right? This is like all the other things outside of the nutritional piece, the inflammation piece, and like that medical side. Botanical medicine. So, whenever we're looking at herbs that we could be bringing into the mix for a patient, these are the categories that I'm typically dipping into. So, number one is antiviral. I really like to utilize my antiviral herbs and my antimicrobial herbs. These are things like echinacea, golden seal, thuja. They're very, very important in helping our immune system focus on that viral component that we see with HPV. Immune stimulants and immune modulators. So these are very different from each other. From my patient who has a weakened immune system, I want to stimulate that immune system. And so we have certain herbs that can jumpstart that into happening. In my patients that have autoimmune conditions, we know that the immune system is already on overdrive. I don't want to stimulate that more because we could potentially make that autoimmune condition worse. Instead, I want to modulate the immune system. So that's how these classifications of herbs are different. It depends on where the person is. If they're weak in their immunity, we stimulate it. If they have the autoimmune piece, we modulate it, which means that we try to calm down that autoimmune space while still providing some support so that their body can fight the virus. Anti-inflammatories are super, super important. We want to decrease the inflammation that the virus is causing on the surface or the inside of the cell. Curcumin is an amazing one. I use a lot of curcumin or turmeric in practice with my HPV patients. Adaptogens are also really important. Adaptogens are our herbs that help us with resiliency. They particularly work on our nervous system and our adrenals. So we have two states of being in the world of the nervous system. We have our fight or flight, which is our sympathetic nervous system, and then we have our parasympathetic nervous system, which is our rest and digest. Most of us exist somewhere in that fight or flight. We are usually in a very sympathetic, like go, go, go nervous system. We have a lot of anxiety. We are on our phones. We have the news. We have the pandemic. There's a lot of influx. There's a lot of information that we are sifting through in our daily lives. We work very hard. We don't rest enough. And so, for those reasons, we have a lot of stress. And over time, our body responding to those stressors, we start to see a weakened immune system, and we just start to see that the body, the foundation there, starts to become weaker, and we don't have that resiliency anymore. So, adaptogenic herbs help us to increase that. These are things like um, ginseng, rhodiola, astragalus, um, licorice. There are several others. Talk to your naturopath about which ones are right for you. But adaptogens will almost always be on board with any naturopath that you see, regardless of the condition, because of that chronic stress that we experience here in the United States. And then nutritive herbs. So these are our herbs that are very nutrient rich. They just help to give us the nutrition that we need. Oat is one of my favorite ones. It is a very gentle herb. Nettles is another one. It has a lot of minerals in there that we won't necessarily get through our diet if we're not eating a very heavy plant-based diet. So this is another way that we can make sure that we're addressing some of those micronutrient deficiencies through herbs. Suppositories and escharotics. So, as naturopaths, we have the freedom and the free reign to create and make individualized treatments for our patients. And one of the ways that we do this is by making suppositories. So, suppositories are small inserts that you'll insert into the vaginal canal. And these are great for HPV because they treat the surface layer of the cervix. So, with my patients that have HPV, or cervical dysplasia, and it's on the surface of the cervix. Think about this as like the cervix. This is the surface, it's that outer layer. If the HPV is only there, then the suppositories are really great there because we put it into the vaginal canal and that medicine can actually have contact with that tissue. This is great because we can make these suppositories with vitamin A, which is super important for healthy cells and healthy tissue. But we can also put things like green tea in it, or thuja, or echinacea. So some of our herbs, so we get that antiviral, anti-inflammatory, and healing properties of the herbs on the cervix. So that's one of my favorite things to do with HPV, is to actually treat that tissue while we treat the inside. So it's like we're treating the inside out. Escharotics is another method for us to remove cells. So, in contrast to the LEAP or the cone biopsy, this is a way that we can remove the surface layer of cells through herbs. What this looks like is the patient comes into the office either once a week for 8 to 10 weeks, or every other week. And they come in, we have the speculum exam, and then I apply enzymes and herbs to the cervix and a little bit of heat, and that helps to break down those cells. It absorbs the herbs, and then chemically, you start to slaw off those cells. So we're doing similar things that the leaf or the cone would do, except we're utilizing herbs to do it instead of using like heat or surgical instruments. It is costly because you have to come into the office. It is time consuming because you have to do it regularly. Like I said, I like for patients to come in at least every week for the first 5 to 6 weeks. If they can't come in every week, every other week for 8 to 10 weeks. So we have to prolong that treatment if they can't come in every week. That can be a pain for a lot of patients. Again, it's not comfortable to be in the stirrups and to have a speculum and to sit there for 15 minutes, but it is an amazing alternative, and we see a lot of amazing results with it. Um, the thing to note about that is escharotics and suppositories work well when the HPV or the cervical dysplasia is isolated to the outside surface. If the HPV or cervical dysplasia is inside the cervix, so now we're starting to go up and into the uterus, these therapies are not as effective because we can't really get the medicine there. We typically need to do something more aggressive, and depending on, again, the type of strain that the person may have of HPV and how severe those cellular changes are, sometimes I do recommend a LEAP. Again, it's really individualized on where that patient is. Foods to avoid. So, standard American diet, we want to decrease all of the big hitters that we see in those types of diets. So, this is the refined sugars and the simple carbohydrates. These are like our white pastas, our pastries, our donuts, our cakes, our cookies, our potato chips, saturated fats. So, fried foods, our pizzas, our hamburgers, processed foods, hot dogs, high sodium foods. The TV dinner meals, canned soups, canned foods, dairy, so cheese, milk, ice cream. All of these things create massive amounts of inflammation. It increases that oxidative threshold, so that cellular damage. It impairs our immune system and the way that we respond to other therapies. And it decreases the energy that we need for immunity. The food is our medicine and it is our fuel. If we have poor quality of fuel, then the machine is going to respond poorly, right? And that machine is our body. So we want to make sure that we're eliminating these other exogenous sources of inflammation while we treat an inflammatory condition like cervical dysplasia. There was something else I wanted to say about that. Oh, yes, so it does not matter if you are taking all of the best herbs, you're taking all of the immune supplements, you're taking the best mushrooms to help with the immune support, you're doing all the things to treat HPV, but your diet is poor in nutrition. You are just shooting yourself in the foot. You're going to take one step forward and two steps back because the host, which is our body, we need to have a nice, healthy environment for those therapies to react properly, right? If we're taking all of this good stuff through supplementation, but our body is poor, our fuel is poor, we're really not going to see the benefits and get that therapeutic yield that we're looking for. So that's really important. Diet truly is our medicine. It's one of the hardest things to treat and to change, but it is also the thing that makes the most change in every condition. Some foods to enjoy for HPV and cervical dysplasia. We want to make sure that we are getting as many leafy greens and vegetables as we can. Leafy greens and vegetables are amazing sources of those micronutrients, vitamins, and minerals that we need. They have some of the plant sterols, the phytonutrients there. And then we get a lot of folic acid, which we need for the DNA in our cells, which is a huge piece in cervical cancer and that cell replication. Um, for my patients who just can't get down all of the fiber, they're tired of eating salads. I prefer that, but whenever we hit a wall, I also like to utilize green powders or to do juices. That's another way that we can get the nutrition in without feeling that we're actually eating more. Green tea is amazing, whether it is topical through suppositories, whether it's oral through oral capsules, or whether it's through the tea that we drink. Green tea is an amazing anti-inflammatory agent, and we have a lot of research that shows how effective it is in treating cervical dysplasia. Fruits and vegetables, again, we get those phytonutrients, we get fiber, we get a lot of the micronutrients that our body needs for processes to decrease inflammation and to support our immune system. Turmeric is excellent because of that anti-inflammatory piece. Turmeric works really well with black pepper. They just help each other to respond more to our tissues when we take them together. Onion, garlic, and ginger, other great antimicrobials. So they kill bacteria, they kill fungus, they kill viruses, and they're also tonics. They're like those pungent herbs that we can get to just tonify our body systems. And then fasting is another great way to help with that metabolic piece and helping us to make some of these dietary changes. Additional things that I like to look for. So if there's an anxiety piece and HPV, getting that diagnosis is certainly something to be anxious about. I like to address that because, again, it keeps us in that fight or flight. It keeps us in that sympathetic nervous system, which decreases our immune system. So we address anxiety, we address the stress. So what are their stressors in their life? How can we change the way that they're managing and experiencing that stress? Prioritizing sleep is uber important. We always do a lot of output, but we don't get enough input back. So sleep is a way that we can put back into ourselves so that our bodies can just work more effectively and optimally. And then really practicing that safe sex and educating on why that's so important is the additional support that we like to employ and practice. So, really quick before I go to questions, there are some signs of cervical cancer that you should be looking for. Now, this is in advanced stages. If you are getting your yearly PAPs, you are pretty safe against cervical cancer because we're seeing it every single year. We're checking in every single year and we're comparing how are you this year from last year to jump on those changes. So, if we see any market progression, we can jump onto it really, really quick. However, some things that we see in advanced stages of cervical cancer for patients where they weren't getting their PAPs or they weren't coming in regularly to check in is a very irregular vaginal bleeding. So if cycles start to get very irregular, we have to rule out cervical changes there. There's a lot of reasons as to why cycles can become irregular, but cervical cancer is one of the things that we want to rule out whenever we have a patient present that way. This is really important for my postmenopausal women. So, menopause is what we consider 12 months with the absence of a period in women without other external causes like pregnancy or other hormonal things like hyprolactin or thyroid disease, right? We've ruled out all these other causes that could make the period disappear. But in a woman who has gone 12 months without any period, she's menopausal, and then all of a sudden she starts to have spotting or this weird bleeding. That is a concerning sign, and you should consult with your doctor as soon as possible because that can be an early sign of some cervical changes that may be alarming. Or higher up in the chain, it could be a sign of uterine cancer. Okay, so that's really important that we are tracking our periods. If we're postmenopausal, we should not be having any spotting. If that's happening, talk to your doctor. Longer and heavier periods. So this is another change in the period in the cycle that can clue us that something may be going wrong. Unexplained or persistent back pain or pelvic pain that we rule out. We rule out other factors like sexually transmitted infections or any obstructive or physical abnormalities to the uterus or the cervix. That pain could be a sign that something's wrong. Pain during sex could be a sign that there's something wrong. Now, I see this one a lot in practice, and there's a lot of different reasons as to why sex can be painful. But if it is persistent, if we've done all of the workup, we've done the ultrasound, there's no obstruction there, there's no bleeding after sex, but there's still pain, I'm going to look a little bit deeper to make sure that the cervix is healthy and that there isn't anything going on in the uterus that could be eliciting that pain. And then an increased vaginal discharge is also something that we want to look out for. Okay, our question. So I see that there was something here in the chat. Oh, we don't have questions. We just have someone cheering us on. Yes, yes. I want to open this up for anyone that has any questions about what we've talked about. We have a couple of more minutes here, and I want to make sure that I give you guys this opportunity. Okay, well, as always, it has been a pleasure to share this knowledge with you all. I hope that this brings some benefit to you and your understanding of HPV and cervical cancer. As always, you can find us at livingwellnessmedicalcenter.com. If you are interested in becoming a patient with me or any of the other doctors at Living Wellness, we do offer a free 10-minute phone consult for you to just get to know us, to talk a little bit about some of your concerns and see if we're a good fit for each other. Our phone number is 480-588-6856. I do have a question here that says, where can you find the suppositories? So usually with the suppositories, we sell them here in practice. Um, Compounding pharmacies also sell them, but you usually need a doctor to prescribe it for you. They don't really make them in conventional pharmacies, and we don't really have a lot of over-the-counter options. So this is something that you would most likely find with your herbalist or with your naturopath. Um, Another thing that you can do is you can make your own. And for my patients that don't have accessibility to the office, I really like Honey Pot's boric acid and herb suppositories. This suppository is available at Target and Walgreens and Walmart. Honey Pot is a very clean product line. And for my patients or those clients who can't really come into office and can't get the suppositories from us there, that's a great alternative for you to start to experiment with those there. All right, guys, well, have a happy weekend, and I will see you next time.